Imagine a disease that literally, super glues your internal organs together.
Oh, yeah.
And then, just to ensure maximum agony, it grows its own rogue, hypersensitive nerves directly into that scar tissue.
Right, literally broadcasting the pain straight to your brain.
Exactly. And then imagine living with that structural chaos, only to have the medical establishment tell you for decades that the pain is, well, probably just in your head.
Or that you just need to relax, which is just, it's infuriating.
It really is. But that is the very physical reality we are tackling today. Welcome to this custom deep dive.
Glad to be here for this one.
We are sorting through a massive stack of sources you provided us. I mean, we've got everything from clinical surgical guidelines and advanced MRI journals to, like, detailed pelvic anatomy textbooks and osteopathic reviews.
And it's a really comprehensive stack.
It is. And our mission today is to answer one highly specific question. We're going to find out exactly how the presence of deep infiltrating endometriosis on the uterosacral ligaments explicitly triggers sharp, localized deep dyspareunia.
Which, just for anyone unfamiliar, is the medical term for severe pain during deep intercourse.
Right. Okay, let's unpack this, because this isn't just a clinical overview, is it?
Not at all.
It's really a mechanical and neurological detective story about what happens when the body's internal support structures are completely hijacked.
That's a great way to frame it, because the data in your sources does something beautiful. It strips away the mystery. It proves this pain isn't just some vague discomfort.
Right, it's not in your head.
Exactly. It is a highly specific, measurable, devastating chain reaction.
So if we want to understand how this system fails, we first have to map out how it's, supposed to work.
Right, the anatomy.
Yeah. We are looking at a very specific piece of physical real estate in the body. So for you listening, imagine the female pelvis, like a heavy-duty tent.
Or even a suspension bridge.
Right, a suspension bridge. You've got the uterus and the cervix hanging right in the middle. And to keep that entire structure suspended and secure so it doesn't just collapse downward under gravity, you have these thick, fibrous anchor cables.
The guy ropes.
Exactly. Those are the uterosacral ligaments. They anchor the cervix and the lower part of the uterus backward, tying them securely to the sacrum.
Which is that triangular bone at the very base of your spine.
Right. So to understand how the pain happens, we need to understand this neighborhood, right?
Yeah, that visual works perfectly because these ligaments sit right in a space called the cul-de-sac.
The pouch of Douglas, right?
Yes, the pouch of Douglas. In a healthy, functioning pelvis, this whole area is lined with a smooth, skin-like membrane called the peritoneum.
Okay.
And its primary job is to act as a completely frictionless barrier. It ensures that the rectum in the back, the vagina in the middle, and the uterus in the front remain completely compartmentalized.
Wait, I want to make sure I'm picturing this correctly. When you say compartmentalized, do you mean this pouch of Douglas is essentially like an empty pocket where these organs can slide past each other?
That's actually a really great way to think about it. It's what we call a potential space. The organs share a tight neighborhood, but they don't share walls. They can move and glide independently.
Got it.
But the uterosacral ligaments themselves, those anchor ropes running through this space, they are not just inert, dead cables.
Right, they're active.
Oh, they are heavily wired. They carry a massive payload of visceral nerve fibers.
Oh, wow.
Yeah, we're looking at nerve roots from T12 to L1 and the S2 through S4 pathways, and they sit right next to a major neurological command center called the inferior hypogastric plexus.
Okay, I have to pause you there.
Sure.
If these ligaments are basically deep pelvic anchor ropes buried way down near the base of the spine,
Right.
how common is it for endometriosis to actually end up there? I mean, it seems so remote compared to, like, the ovaries.
Well, the clinical data in the sources might actually surprise you. The uterosacral ligaments are the most common location for deep endometriosis.
Wait, really? The most common?
Yeah. Depending on the study, the prevalence is anywhere from 20% to a staggering 70% in cases of deep infiltrating endometriosis. 70%. That is an incredible majority.
It is absolute prime real estate for this disease.
Wow.
And because these ligaments act as the boundary line between the rectum and the vagina, when the disease takes root there, the mechanical consequences are just, well, they're catastrophic.
Here's where it gets really interesting. Because if these ligaments are supposed to act as independent anchors in a frictionless space, what happens mechanically when endometriosis physically breaches that barrier?
Right. We have to look at intimacy.
Yeah, we have to connect this to the actual mechanics of intercourse to understand the pain.
So let's start with the mechanics of a healthy pelvis.
Okay.
During deep penetration, the upper posterior part of the vagina, the area right behind the cervix, it needs to expand.
It has to stretch.
Exactly. It yields.
Mm.
Because that smooth peritoneum keeps the organs separate, the upper vagina can glide freely against the rectum right behind it. There's natural mobility.
Like pushing against the side of a flexible tent. It just gives way.
Exactly.
Yeah.
But now introduce deep infiltrating endometriosis onto those uterosacral ligaments. And these are endometrial-like cells, right?
Yes, meaning they respond to hormones, they bleed and shed just like the lining of the uterus during a menstrual cycle.
But they are trapped deep inside the pelvic cavity.
Right. The blood and tissue have absolutely nowhere to exit.
So the body has to respond to this trapped bleeding tissue.
It responds with a massive localized inflammatory attack.
Yeah.
And over time, that chronic cyclical inflammation forces the tissue to physically change.
Into scar tissue.
Dense scarring and fibrosis. And fibrous tissue is thick, it's rigid, and it is completely inflexible.
One of the sources actually described this fibrotic tissue as acting like superglue.
That is chemically and mechanically perfectly accurate.
That's terrifying.
It is. That fibrotic scar tissue obliterates the smooth boundaries of the peritoneum. It literally glues the front wall of the rectum directly to the back wall of the vagina.
Oh my God.
And then it fuses both of them to those now rigid, inflamed uterosacral ligaments.
So that frictionless sliding space, the pouch of Douglas, it just gets completely sealed shut.
Sealed shut with concrete-like scar tissue.
So for you listening, think about what this means mechanically. When deep penetration occurs in this diseased state, it is no longer striking a flexible, yielding barrier.
Not at all.
It is striking a rigid, inflamed, glued-together wall of internal organs that has lost all of its natural mobility.
Yes.
The mechanical force of intercourse is directly stretching and yanking on these stuck, starred ligaments. And that violent pulling explicitly triggers the sharp, localized pain of deep dyspareunia.
And what's fascinating here is how this mechanical reality perfectly validates what patients report in the clinic.
How so?
The sources note that the pain can vary wildly in intensity based purely on sexual position.
Oh, because of the angles.
Exactly. If the pain were just a generalized ache, position wouldn't matter as much. But because the pain is mechanical, certain angles pull more directly on the fused ligaments than others.
It's pure physics. You are yanking on an inflamed, glued-down anchor rope at different vectors.
Yes.
And for anyone listening who has ever been told that this pain is psychogenic, that it's just anxiety or you just need to have a glass of wine to relax.
Right, the gaslighting.
This data completely obliterates that. We are talking about the literal structural fusion of internal organs.
The validation is undeniable, but mechanical tension alone doesn't actually explain the quality of this pain.
Right, because if I, pull on a normal thick scar on my arm, it might feel tight or uncomfortable, but it doesn't send me to the floor in blinding agony.
Scars usually lose sensation.
Exactly, they don't amplify it.
Right, and that is the crucial difference here. This is where the pathophysiology gets truly sinister.
Okay.
Endometriotic lesions don't just sit passively on top of these nerves getting bumped into. They actively alter the neurological landscape of the pelvis.
Oh, wow.
Yeah, the clinical sources detail a deeply invasive process called neurogenesis.
Wait, neurogenesis, like growing new nerves?
Yes. The inflammatory soup created by these trapped lesions contained incredibly high levels of nerve growth factors.
So the disease is making its own nerves?
It essentially hijacks the local environment and commands the body to grow new, raw, sensory pain fibers directly into the endometriosis tissue itself.
That is, it's like a computer virus.
How so?
Well, it doesn't just sit on your hard drive and corrupt a few files in the background. It actively rewires your computer's motherboard to ensure it sends constant blaring error alerts.
That is a brilliant analogy. And to make matters worse, while it's growing these new hypersensitive nerves, that rigid fibrosis we talked about earlier.
The superglue.
Right. It is simultaneously physically entrapping and crushing the existing pelvic nerves.
Oh, man.
So you have ancient structural nerves being suffocated by scar tissue right alongside brand new raw nerves grown directly into an inflamed tumor.
Which brings us to the concept of central sensitization, right?
Yes, exactly.
Because sources spend a lot of time on this, but I have to admit, I struggle to visualize it. I understand the local nerves screaming from being pulled and crushed.
Yeah.
But how does the brain itself get rewired? Like, is it actually changing the brain's physical structure?
Well, it is changing how the central nervous system processes information. Central sensitization is basically neuroplasticity working against you.
Okay.
When the spinal cord and the brain are bombarded with high-intensity pain signals from those T12, L1, and sacral nerve roots month after month, year after year,
The brain just gets overwhelmed.
the central nervous system gets exhausted. Eventually, it says, okay, this constant state of emergency is our new normal.
Right.
So to adapt, it literally lowers its threshold for what it considers painful.
So the synapses are actually changing how they fire.
The alarm system gets stuck in the on position, the brain becomes hypervigilant.
So for you listening, think about what this means for your daily life. It means that over time, your brain turns up the volume dial on your pain sensing system to the absolute maximum.
Exactly.
Experiences that should not be painful at all, like digestion, wearing tight pants, sitting down too fast, or just light pressure,
Right.
they suddenly register as agonizing level 10 pain.
It explains why deep dyspareunia can persist and throb long after the physical trigger of intercourse has actually stopped.
Because the volume is still turned up.
The local nerves are multiplying and screaming, and the brain has been chemically conditioned to amplify that scream.
So what does this all mean? I mean, if we step back and look at this logically,
Yeah.
if we know exactly where the pain is coming from, and we know these specific nerves in the uterosacral ligaments are the ones screaming, why can't surgeons just go in and cut the cord?
That seems obvious, right?
Just sever the nerves in those specific ligaments and stop the signal from ever reaching the brain.
It is the most rational conclusion to draw, and the medical community actually operated on that exact logic for years.
Right, really?
Yeah, there was a highly popular surgical procedure called LUNA.
LUNA, laparoscopic uterosacral nerve ablation.
Exactly. The entire premise of LUNA was to go in surgically and burn or completely transect the uterosacral ligaments right where they attach to the back of the cervix. The goal was to intentionally destroy the nerve plexus inside the ligaments, essentially severing the main power cord to the pelvic pain.
Structurally, that makes total sense. If you cut the wire connecting the alarm to the speaker, the alarm stops ringing.
Right.
So, did it work?
It failed comprehensively.
Wow. Completely.
The clinical trials and meta-analyses in the sources are definitive on this. LNA is largely ineffective for treating endometriosis-associated pelvic pain.
How?
Well, patients might experience a brief placebo effect or very temporary relief, but long-term, the pain returns just as fiercely.
I just don't get it. If you physically sever the wire, how is the alarm still transmitting?
Because the pelvic nerve anatomy is vastly more complex than a single wire. It's a highly redundant, overlapping web.
Okay.
Think of it less like a single cable and more like a massive Wi-Fi network.
Ah, I see.
If you look at the anatomical maps in the sources, you see that pain fibers from the ovaries, the upper pelvis, and other tissues, they completely bypass the uterosacral ligaments.
They just take a different route.
Exactly. They travel up the aortic plexus or route directly to the dorsal root ganglia through completely different anatomical highways.
So you cut the Ethernet cable, but the disease is still broadcasting over Wi-Fi, Bluetooth, and cellular data.
Precisely. You've just blocked one pathway out of a dozen.
That's incredibly frustrating.
And the failure to stop the pain wasn't even the worst part.
Wait, it gets worse.
The LNA procedure caused significant life-altering collateral damage.
Oh, no.
We mentioned earlier that these ligaments carry fibers from the S2 through S4 nerve roots.
Right.
Those aren't just sensory nerves, they carry the autonomic signals that control your bladder and your bowel.
Oh, wow. So if a surgeon aggressively cuts or burns those ligaments just trying to stop the pain,
They risk severely damaging the patient's ability to urinate or have a normal bowel movement.
that is devastating.
The sources detail cases of urinary retention, chronic constipation, and severe pelvic floor dysfunction following aggressive nerve ablation. You are essentially trading one nightmare for another.
Okay, so if cutting the cord doesn't work, and we obviously can't just leave these organs glued together with fibrotic scar tissue, what is the modern approach?
Right, how do we fix it?
Yeah, how do surgeons actually handle this now?
Well, the entire philosophy of modern endometriosis surgery has shifted toward what is called nerve-sparing surgery.
Nerve sparing.
Instead of trying to blindly destroy the nerves to stop the pain, highly skilled surgeons now use techniques like laparoscopic neuronavigation.
Neuronavigation.
Yeah.
How does that actually work in an operating room? It sounds like you'd need, I don't know, a microscopic GPS.
That's essentially what it is. Surgeons use specialized intraoperative probes that deliver tiny microamperage electrical stimulations to the tissue.
While they're in surgery.
Right, because the microscopic nerves of the hypogastric plexus are completely buried within all that dense fibrotic scar tissue.
The superglue.
Yes, so the surgeon will stimulate a millimeter of tissue and watch for specific physiological responses,
Like what?
like a tiny bladder contraction or a rectal muscle twitch.
It's like high-stakes bomb defusal. They have to map the safe zones before they can cut.
It is incredibly meticulous work that can take hours.
I can imagine.
Once they successfully map out where the healthy nerve networks are hiding, they painstakingly dissect and remove the fibrotic endometriosis lesions.
They remove the superglue.
Exactly, while carefully preserving the underlying neurological web.
So the goal isn't to kill the messenger anymore. The goal is to carefully extract the hostage.
I love that. Yes.
You remove the tumor that's crushing the nerves,
Yeah.
and you unglue the organs so they can move freely again.
By restoring the mechanical mobility of the pouch of Douglas, you stop the physical pulling and yanking during intercourse.
Right?
And by removing the source of the inflammatory nerve growth factors, you slowly allow the central nervous system to calm down and dial the pain volume back to normal.
That is a phenomenal evolution in how medicine approaches the body.
It really is.
So, to recap this journey for you listening, when we talk about deep dyspareunia caused by endometriosis on the uterosacral ligaments, we're looking at a highly specific, catastrophic mechanical failure.
Absolutely.
The disease creates a fibrotic scar tissue that literally glues the vagina and the rectum together, destroying the natural flexibility of the pelvis.
The tent collapses.
Right. And combined with that mechanical trap, there's a literal neurological hijack where the lesions grow their own new nerves, crush the old ones, and trick the central nervous system into a permanent state of hypersensitivity.
You are dealing with stuck anchors and screaming wires.
It is a perfect storm of pathology.
Yeah.
But understanding the exact mechanics of it is what has finally led to these nerve-sparing surgical techniques that can actually give patients their lives back.
It's an amazing breakthrough.
It really is. But before we wrap up this deep dive, there's one final piece of the puzzle from the MRI sources that we have to talk about. We've mapped out how the pain happened, but you mentioned a theory about how this endometrial tissue even gets onto these deep pelvic nerves in the first place.
Yes, and this is a concept that completely upends traditional medical thinking.
Okay, I'm ready.
Historically, the dominant theory for how endometriosis starts is called retrograde menstruation.
Right, I've heard of that.
It's the idea that menstrual blood flows backward through the fallopian tubes, spills into the open pelvic cavity, and lands on organs and ligaments.
Like seeds falling into a garden.
Exactly.
Which makes sense structurally. If it spills, it lands on the outside of whatever is in the neighborhood.
It does, but it doesn't explain everything.
What's it missing?
Specifically, it doesn't explain how deep infiltrating endometriosis can sometimes be found entirely inside a nerve sheath,
Wait, inside?
without a single trace of the disease on the outside of the nerve.
Inside the nerve. How does a spilled seed get inside a sealed neurological cable?
It can't,
Right.
which is why the radiological sources highlight a mind-bending alternative theory.
Let's hear it.
It's a combination of the coilomic metaplasia theory and modern stem cell research.
Okay.
The theory proposes that there are pluripotent progenitor stem cells, basically blank slate, undeveloped cells left over from embryonic development,
Yeah.
already living naturally inside the pelvic nerves.
Okay, I think I see where this is going, and it is terrifying.
Under the right hormonal triggers, immunologic failures, or even due to repetitive microtraumas to the nerve itself,
These blank slate cells are triggered to mutate.
they undergo metaplasia. They transform into functioning endometrial tissue directly within the nerve itself.
Wow. It suggests the disease isn't invading the nerve from the outside in, it's growing from the inside out.
It is a cellular betrayal from within the body's own wiring.
That is just wow.
And if this theory holds true, it completely explains why this specific form of the disease is so incredibly difficult to map.
Because it's hiding inside the cables.
Exactly. And why it causes such disproportionate neurological pain, and why surgical excision has to be so devastatingly precise.
We started this deep dive talking about the expectation of perfect engineering in the human body. The idea that everything is supposed to compartmentalize, glide, and adapt.
Right.
But what we found is that when those heavy-duty anchor ropes, the uterosacral ligaments, are compromised, the entire architectural and neurological integrity of the pelvis just collapses.
It's a system-wide failure.
It leaves you wondering if the very structures designed to hold us together can be reprogrammed from the inside out to cause us pain. How well do we really understand the blueprints of our own bodies?
It's definitely something to think about.
Something to mull over. Until next time.